Hello, my name is Maria Isabel Esparza from the University of Texas Health Science Center in San Antonio. I am honored to present our work on the predictors, management, and prevention of the distal embolization during infrainguinal endovascular therapy. I would like to begin by thanking my mentors, Drs. Anand Prasad and Subhash Banerjee, for their guidance with this project. I would also like to thank the EPD investigators and staff who contributed to this study. This abstract examines data from the multi-center XLPAD registry based at the University of Texas Southwestern Medical Center and the Dallas VA Medical Center. This is an ongoing registry which includes infrainguinal interventions from 20 sites worldwide and has enrolled over 2,000 patients. Based on results of the research by Nicholas Shamas and colleagues, we know that distal embolization is a common complication of endovascular therapy. While the majority of these events are subclinical in nature, the liberation of macroparticles in the distal circulation is reported to occur frequently. Clinically relevant embolization, in other words, events requiring interventions by the operator or resulting in clinical symptoms, can lead to significant concerns on the part of the physicians and result in pain and risk of tissue loss in patients. The prevention of embolization with embolic protection devices, or EPDs, therefore makes sense. The use of EPDs, however, adds costs and time, which are important considerations. The purpose of the present study was to examine the incidence and predictors of distal embolization in a contemporary registry of infrainguinal intervention. We also wanted to look at the impact of EPDs in the prevention of embolization and the modalities used to treat embolization when it occurs. We analyzed data from close to 1,500 patients undergoing mostly femoral popliteal interventions. Most of the patients were male, with a mean of 65 years. More than half of this cohort had diabetes. The overall incidence of clinically relevant distal embolization was 1.3%. Multivariate predictors of distal embolization included treatment of chronic total occlusions, in-stent restenosis, any use of atherectomy, specific atherectomy devices which were associated with higher rates of embolization included use of jet stream system and the use of laser atherectomy. Other important predictors included the presence of visible thrombus, long lesions more than 111 millimeters, and the presence of diabetes. Treatment of distal embolization was successful in all the cases and largely involved the use of aspiration thrombectomy, with less frequent use of atherectomy or stenting for salvage therapy. Of the entire cohort examined, EPDs were used in a quarter of patients. The majority of the EPDs used were Covidian spider filters, with a smaller number of Proteus balloons and Abbott NAV6 filters. In this select group of patients who had EPDs, the rate of embolization was 2.1%. The present data demonstrates that the rate of clinical significant distal embolization is just over 1%. And in the cases where physicians used EPDs ahead of time, the rates were 2%, despite the use of these devices. We also demonstrate that most cases of distal embolization can be managed successfully with manual aspiration thrombectomy devices. Based on our data, the treatment of CTOs, long lesions, in-stent restenosis should prompt the consideration of EPD use. Distal filter use should also be considered as an adjunct to atherectomy, particularly when jet stream or laser devices are used. Thank you for your time.